Morning, everyone. Welcome to the Arkansas Behavioral Health Integration Network virtual meeting. We are so glad you're here with us this morning. I'm Kim Schuler, and we have the pleasure of Dr. Kurt West speaking with us this morning. I'm going to ask Dr. Gibson to go ahead and give his formal introduction, and we'll start with the program.
Yeah, welcome everyone. I am so excited to have Dr. West present this morning. There's been so much stress for each of us as individuals, as well as healthcare providers. And a couple of weeks ago, Dr. West presented this presentation or something similar to it to the Arkansas Psychiatric Society. And I was so impressed and pleased with the content as well as the practicalities. And so that's one of the reasons I was spreading this invitation out beyond where we normally, most of the time we are having people on this who've been involved in the CPC Plus stakeholders and Arkansas Behavioral Health Integration Network. So happy to have so many people on. And if you have a chance, just type in your name and your role and your location, and we will be moving along that way. But Dr. West is an Associate Professor of Psychiatry and a scientist at the Center for the Study of Traumatic Stress at the Uniformed Services University of Health Sciences. He did get his medical degree from the University of Michigan Medical School, and he is board certified in psychiatry and a distinguished fellow of the American Psychiatric Association. And he is serving on the American Psychiatric Association Committee on the Psychiatric Dimensions of Disaster. And Dr. West, welcome. And if you don't mind, give us a little bit more about your history and how you came to even be doing this presentation. But thank you so much. And for being here. Welcome, everyone.
Absolutely. And thank you for inviting me. I'm really happy to be here, especially in a group that describes itself as integrated behavioral health, which is very much what my psychiatry upbringing has been all about. And you'll hear a little bit about that as I go through the presentation. So let me go ahead and get my pictures up here. There is a little bit of interaction here in this presentation, so have your phone ready because in a few slides I'll flash up a QR code that'll take you to a brief poll that'll let you just give me some responses, and it enriches the discussion. But yeah, as Patty mentioned, I am a psychiatrist at the Uniformed Services University, which is America's medical school. One of the big reasons I came to this is I am a retired Navy psychiatrist. I retired about 2 years ago after 16 years as a psychiatrist. And during that time, I was very much involved as an embedded behavioral health provider to various ground combat forces, primarily the Marine Corps. And this is really what this grows out of is my experiences with combat and operational stress control and how I have seen them become so applicable as we look at the stresses that healthcare workers have encountered over the past year. And so you'll see this whole idea is try to integrate those two worlds in a way that is understandable to everybody and can hopefully conceptually drive the policies and interventions going forward. So just to be clear, yes, I do work for the government, but these are not the views of the government. These are mine. I don't have any conflicts. I don't make money off of this, but I am doing this on my official time. So the government likes that I say this. I'm going to take a brief digression into disaster and psychological responses, which is one of the areas that our center really focuses on. And then I'm going to talk about my own experience with combat and operational stress control and some of the history of combat and operational stress control, and try to weave that into what is currently many approaches to hospital wellness programs. And out of that, my hope is that this will be very conceptual. Unfortunately, I can't give you great details because the details don't exist, but to think about a sort of a tiered approach to supporting a workforce and thinking about applying those levels of support across the various phases of COVID response. Just a little bit about where I'm from. As I mentioned, this is, I work at America's Medical School. So we've been around since 1972. Our first graduating class was in 1976. And we train uniformed healthcare providers for the Army, Navy, Air Force, and the Public Health Service. And so typically we have about 185 students per class right now. We also have schools of advanced practice nursing. There's a postgraduate dental college and a medical and clinical psychology program. There's many other graduate programs that are run through our university. Okay, so to start out, I'm going to assume that everybody on this call has in some way been affected in their work by COVID. And so just to give a one-word response, and you can respond as many times as you want. There's several different ways to respond that I'm offering. But think about, what things have you had to think about? What reactions have you had? What things have you done? What behaviors have you engaged in response to COVID? There we go. Okay. It always takes a little while to break the ice, and then it starts to populate. I love these word clouds because it gets you to start seeing how concepts and responses overlap. And I'm seeing things in there, ideas of isolation and anxiety. I see the word parent in there. Absolutely. This is something that's been a big deal, especially in COVID. Yeah. Okay. So the key things are people are feeling isolated and overwhelmed. And this isolated, overwhelmed, and anxious, and things are disrupted. I love it. And this is a great sort of segue into talking briefly about what are typical reactions to disasters. And I'm going to start with just the broad brush of disasters and not just pandemics. So this is something that, we've studied. But if you were to look at it in terms of psychological reactions, well, they start thinking about psychiatric disorders. Tends to be the first place we look. Oh, people are going to get PTSD. People are going to get depressed. People are going to start committing suicide, right? That is an outcome. That is a psychological outcome of disasters. But I will tell you, it represents a minority of the outcomes. What is far more common, are people experience distress reactions that are often transient, and or they engage in health risk behaviors in response to those distress reactions. So people will commonly have difficulty sleeping. They'll report in a decreased sense of safety. And perhaps in response to that, they may turn to substances as a means to cope. Does that mean that they are developing alcohol use disorders? Typically, no. The typical example of alcohol use after a disaster is you see a transient increase, but then most people return to their baseline. So there's not necessarily an increased incidence of clinical disorders, but it represents a health risk behavior. Now, why are those important? Well, because in the aftermath of a disaster, you pointed out, people are overwhelmed. People are not just overwhelmed, but systems and the resources are also overwhelmed by the event. And so it requires a substantial amount of effort and work by the population to recover. And so if they're impaired by these distress reactions or these health risk behaviors, they are less able to contribute to recovery. So this is one of the challenges, and in my next slide, it'll start to make a little bit more sense. But recognizing that there's this whole spectrum of reactions that are well short of clinical disorders that need intervention, that need support in some way. And then the good news story is that the substantial majority of people following disaster demonstrate what we would call a resilient trajectory. And so most people, even if they have these transient reactions or risk behaviors, end up in a state of resilience and not in a state of disorder. If we look at COVID and what happened to healthcare workers and what types of concerns they had. Now, this is a somewhat older article. It's from kind of mid to early 2020, as in the early phase of the pandemic. What were the things that were on people's minds, or what were the things that were causing distress in healthcare workers? Clearly, recognizing that they were protected or at risk. So trying to make risk decisions and understand when they are at risk, when their families are at risk as a result of their work, and what can be done or is enough being done to minimize that risk. So do they have PPE? Can they get tested? Is the testing reliable? How do they know if they've been exposed or not, or if they are putting others at risk? But then on top of that, knowing that, what is the organization going to do if I get sick? Will there be, can I take care of my family if I get sick as a result of exposure at work? Will I get, and this is, I don't know if this applied to the systems, it typically does in a lot of systems, especially if the demand gets really great. Physicians, nurses, other healthcare workers will get redeployed from their usual practice setting into an inpatient setting or into an acute care setting that while they are trained and they know how to do that and they're certified to do that, they are by no means proficient in that. And so certainly in some areas, we saw a lot of anxiety and distress over this idea of redeployment. And then the idea of getting adequate information. So I told you I was going to tell a little bit about my own story. So how did I get into this? Well, our center, the Center for the Study of Traumatic Stress, has for the longest time been involved in consultations to both government and outside organizations. And so when the military medical teams deployed to New York back in April of last year, one of the first places they reached out to was us to say, okay, well, how do we help our own personnel, and how do we manage what should we be looking out for? What should we be prepared for? So we already had the connection with the military teams that were going up there. Interestingly, I don't know how much you know about the history of this. So in New York City, originally, the hospital ship pulled up, tied up to the pier, and the Army Field Hospital personnel deployed to the convention center in New York City. Within a few weeks, they recognized that that was not the optimum use, and so some of the physicians and nurses were actually being moved out to some of the hospitals across New York City. Along with them came these embedded behavioral health that were sort of checking up on them, and they would swing by periodically. And so the hospitals were seeing these Army doctors and nurses show up, and then this Army psychologist or psychiatrist would come by and just kind of chat with them and check up on them. And they were like, well, wait, what's that? Because they had not experienced this. And so out of that, partly in conjunction with a request from the mayor's office, but also looking at the whole Greater New York Greater New York Hospital Association and the New York City Health and Hospitals leadership, pulled together the military leadership, the hospital leadership, and us and the wellness organizations and said, hey, let's come up with, can you teach us some of this stuff? And this created this Hero New York program, which I'll talk a little bit more about later. But that's sort of where these two worlds of disaster psychiatry, embedded behavioral health, and hospitals came together last year. So let me take a sidebar here and tell you a little bit about military combat and operational stress control. I don't know if anybody in the group has a military background, but the idea of helping individuals navigate extreme environments has been part of military training, not necessarily military medicine, but military training for a couple centuries at this point. It really started to get codified in and around World War II as psychiatry became part of military medicine in a much bigger way, but also the numbers of psychiatric casualties as the result of combat were much greater starting in World War I. And out of World War I came these initial principles of proximity, immediacy, expectancy, and simplicity. And those were the first fundamental principles of combat operational stress control. Take care of people as close to where the battle is as possible. Do it as soon as possible with an attitude of most people will recover from these reactions, and keep it simple. And so those have always been sort of at the heart of any more complex version of combat and operational stress control. As wars progressed, psychiatrists, psychologists, and social workers now remained a part of the medical force, but also evolved into these roles that we would call embedded roles. And so that's me in Afghanistan in 2010. And I don't look like a doctor, do I? I look like the people that I'm trying to help. And so this idea of, and this was actually shot when we were out on the shooting range, out at the edge of the base, after we first got there. So, but the idea of having mental health personnel embedded within stressed groups and spending time not just treating them and evaluating them, but spending time interacting with them in their environment and their leadership within that environment was built around this model of sort of helping them become more psychologically minded, but also helping us become more aware of what's normal, what's not normal, what types of things might work or be effective with individuals that are part of those groups. It also really, in the most recent conflicts, we got into a rhythm of what we call deployment cycle preparation, recognizing that individuals would go through these cycles where they'd be getting ready, they'd go do a deployment, and then they'd have to come back and recover and start getting ready again. So it becomes very much a cycle. Out of this has become sort of the model of how we look at stress reactions within the military, and that is looking at them as a continuum. And so this idea of green, yellow, orange, and red was really something that we developed, I want to say 2007, 2008, alongside the military leaders. So we had to use language that they could understand, but we also had to create this idea of, look, there's not just okay people and sick people. There are people that are struggling in between, and there's different interventions depending on where you exist along this continuum. And for the most part, the key concept here is that most people spend any given day bouncing back and forth between ready or reacting. So, some of you may have been rushing to get out the door and you knocked your coffee over. right? And you didn't get to have your coffee. So guess what? You moved from green into yellow. Well, do I need to call a social worker in to come in and do an assessment on you because you're crying because, it's just a little bit more than you could take this morning? And so, recognizing that there are these different shades. And we introduced into here this idea of an injured category, this idea of somebody who's not clinically ill, but if we don't do the right things, they might tip over into this category. But if we do the right things, we get them back into this kind of yellow green oscillation, right? And when I say we, that doesn't just mean the shrinks and the nurses, right? It means sometimes it's a small unit leader who sits down and recognizes somebody's getting close to this and says, they do some of their simple leadership level interventions and see how the person responds. And if, for example, sitting down and talking to somebody after a patrol that had an incident where somebody was seriously injured and evacuated, and a leader sees one of their soldiers isolating and goes over and talks to them, and they kind of bounce back and they get back over here, guess what? They don't need to get sent to the psychiatrist, right? They just need some support, whether it's peer support, leadership support. So this whole idea was meant to empower people along the entire continuum. So lately we've been kind of toying with how do we adapt this in language that healthcare workers can understand, because healthcare workers are not soldiers, right? Um, and so there are ways that the first thing I think the first thing that hit me was healthcare workers didn't like the idea of being injured. So and again, this is still a work in progress. I don't even have a citation to give it because we haven't published it yet. But it's trying to get those same concepts and introduce the types of intervention that should be contemplated at these different levels along the continuum. So as I mentioned, there's different models of intervention in combat and operational stress control. I kind of mentioned PIEs, the very simple concepts. The Navy combat and operational stress control tried to implement this idea of the 7 C's. It was not my idea. It's kind of corny. And honestly, some of the feedback that I've gotten from leaders is, don't give me this much complexity. This I can remember. This is 4 things. And when I'm stressed and they're stressed, give me 4 things to remember, and that's going to work. Okay. So, but again, you can put any level of complexity, and you could say that a lot of these sort of fit within these, and they're sort of nested within them. But what I'm going to offer is maybe a more overarching model that many of you are probably already familiar with. And I'm just going to kind of give my take on this and how it ties in with healthcare workers and the stress of COVID or any infectious outbreak or any demand surge for that matter. And that would be psychological first aid. And so most people, when they hear psychological first aid, the first thing they'll think about is maybe American Red Cross. And this is something that they teach. And well, is it an intervention? Is it a therapy? What is it? And the answer to that is, well, kind of yes and kind of no, and kind of it's kind of a lot of things to a lot of people. What I will say is here's what I'll say. It is an evidence-informed conceptual framework for intervention. So let me just put it that way. It's an evidence-informed conceptual framework. And the core elements, if you want to remember, if you love mnemonics, I just say sketch, right? And it's safety, calming, efficacy, connectedness, and hope. But there's a little bit of a logic and an order to it. And so, you think of the typical, and this is identifying and helping distressed individuals and groups. So what are some of the things you have to accomplish? Well, first of all, you have to accomplish a sense of safety. And if I will argue, if you can't get the individual to recognize a sense of safety, it's going to be hard to do any of the other things. From a combat and operational stress control perspective, that would be, you don't try to do psychodynamic therapy when bullets are flying over your head, because that's not being processed. So you need to get people into a space where they can take in information and process it in a more cognitive manner instead of just an emotional threat response manner. So along those lines is interventions that, or any intervention that induces a sense of calm or helps bring the person down from a state of elevated arousal. And so I always, whenever I present this idea of these concepts of psychological first aid, these are the first two things you have to do. And then you move on to the others that will help people move on from their distress reactions. And those would be recognizing a sense of self and collective efficacy, in the sense that we can get through this. We have the abilities and the tools to recover from this, or if you wanted to say the case of COVID, we have the skills to care for this excessive number of patients that we've never imagined we could do. But to, again, in whether it's through talking about it or whether it's just through accomplishing it, recognizing that sense of efficacy. The other key component is and this hits to what you all identified as one of the most stressful things about COVID, is that sense of isolation. And we are communal organisms. And so using reinforcing and developing a sense of connectedness for the individuals to recognize, I'm not in this alone. I'm not the only person who feels this way. I'm not the only person who is struggling with this particular problem. And so both using, you know, team problem solving or just emotional support, whether that's on a one-on-one level or within a small group level or at an organizational level, to say that we are all in this together. The idea of connectedness and being part of a larger community. And then finally, instilling a sense of hope that it's not always going to be this way or this bad, even if it's maybe going to get worse, which I think we all experienced at the beginning of COVID. And we've, not only has it gotten worse, it's gotten better, and then it's gotten worse, and then it got better, and then it got much worse, and now it's gotten better again, and now it's getting worse again. And so being able to maintain a sense of hope, even in the face of these sort of ups and downs. So what do we see in sort of the standard healthcare system and sort of wellness approaches? Definitely, there are a reasonable number of self-help resources that are offered to healthcare workers. I will say, in the early stages of COVID, we had this explosion of hotlines, and then we sort of had an implosion because people didn't really use them as much as was anticipated. And maybe we'll have a chance to have some discussion about that. Every healthcare organization has an EAP. And depending on the organization, but in general, I think we found that that was not the adequate model to handle what we were faced with, or what we've been faced with COVID, because it's not a system that's designed to handle both the volume and the intensity of what's been emerging. And we also saw that many systems said, well, we'll just make more, we'll make up more appointments available, we'll create groups, we'll create drop-in groups. And I will tell you, with many of the systems that we consulted with, people didn't use those. And so they created capacity that wasn't used. So something about healthcare workers, or something about healthcare workers in COVID, this is not what they wanted or what they needed or what they were going to take advantage of. So this was sort of the state. And then where I want to go with this is talk a little bit and think conceptually about, okay, well, what could we be doing better structurally? And so where I would take this then is consider this sort of model of tiers of support and what is going to help the most people, not just those who rise to a level of clinical illness, right? So the thought being is if you are able to intervene and seed the environment with individuals or just everybody that recognizes some of these principles. And so obviously, I would not. I would argue that we've done a fairly good job of getting information out to people about self-help resources, and that would be things like, meditation, making sure you're paying adequate attention to your rest cycles, and ensuring that people are able to get adequate rest cycles. Talking to people about, or making sure people are aware of risks associated with excessive use of alcohol or other substances as a means to cope. There's a lot of apps that are out there that you can do different types of relaxation exercises. A lot of healthcare systems offer sort of break rooms, or even break rooms where there's facilitated self-help interventions, whether it's yoga or meditation, things like that. I think we do a pretty good job of getting that out to people, but it may not be enough. And so above that is, if you think about this idea of connectedness, peer support. Now, when I say peer support, that ends up taking a lot of forms, and later on I'll give you some examples of what some organizations have done. A lot of times peer support is interpreted as creating a system whereby you implant trained peer supporters amongst the population, and so everybody knows who's the person that they go to if they need peer support. I would advocate that, my idealistic vision is that somehow we empower every peer to be an adequate peer supporter, because I think we know that the culture of medicine is such that peer support is something that is not always available to us, and that whether it's sort of self-stigma that says, I don't want to be perceived as the person who's having a problem, or I don't want people to look at me as if I might be unreliable, or the sense that we're all too busy, and I don't think that's so much the issue, but that may be, again, we do a lot to talk ourselves out of going to talk to another person that we would otherwise be close to and working right alongside. So thinking about processes or information that's circulated within the organization that promotes healthy peer support. And I'm not saying that peer support programs are bad. They're not, but they might not be enough. Then I would say above that is leadership and organizational support. So if you go back to that JAMA article that sort of identified all the stresses of healthcare workers, one of the clearly identified needs was that healthcare workers wanted to feel listened to. They wanted to feel that once they were heard, that positive changes would occur as a result of the problems that they were bringing forward. That is something that happens at an organizational level. So if nursing staff is saying that, working, that working, one specific aspect of working conditions is not conducive to their being able to sustain the workforce, and the organization says, well, that's fine, but we're not going to make that change. You can throw all the self-help at those people you want. You're still going to have more distress reactions. You're still going to have more risk behaviors, and you're still have more people that are going to progress into illness. So the organization must recognize that at times they're going to have to make changes or communicate in ways that are still intended to sort of bolster their workforce. I will add to that, there are leadership interventions that are nothing to do with, you might think they're nothing to do with mental health, but they may have a huge impact. And to help and when I say leadership, I'm thinking more sort of at the mid and lower levels of leadership, whether it be nursing supervisors, charge nurses, things like that, to recognize that certain interventions that they may do are actually a form of psychological support. So if one of your nurses on a shift that day had one of their COVID patients, die, and they couldn't, and it was very difficult for them. And this happens a lot of the time, but it's not recognized as a psychological intervention where somebody says, well, let me help you out with patient care, or let me lower your load for the day, or something like that. But recognizing that a person is challenged and presenting some relief in a supportive way is actually a psychological intervention. And so empowering leaders to recognize that, I think, is very important. And then at the top is this idea of clinical care, but also screening and referral. Now, you could argue, okay, well, how should I do that? Well, that's a tougher problem, right? Because as healthcare workers, we all know how to answer the questions so that you'll go away and leave me alone, right? So if I answered your PHQ-9 honestly, you're going to say, oh my God, you shouldn't even be coming to work today. But we know how to answer those questions. So, and we know we've seen this in military screening, right? In the military, we're very good at doing routine screening and asking questions about symptoms. And when it's in a way that's recorded and it's identifiable, people are fine, or more people are more fine. When it's anonymous and you can just say whatever's on your mind and it's not going to be attributed to you, symptoms go up. So thinking about ways that people can, and you do actually see this now, that there are ways either through apps or through websites where people are able to sort of self-report their symptoms and get some feedback about, well, you're looking actually more stressed than you think, and then potentially being linked to resources, but it can be done anonymously. And one of the neater things I've seen lately is that actually systems, and I think I have an example of this, if not, I'll mention it, but there are systems where the organization can actually get the aggregated anonymized information about how their workforce is doing without anything being attributable. And the employees can get a chance to recognize where they are on their continuum, and be linked to resources, whether it's SelfHelp Resources, or here's how you can get an appointment to come talk to somebody, or even better, maybe here's somebody that pops up on telehealth and is available on fairly short timeline, so that they can get the help that they need when they need it in a way that's convenient to them. Because if you're working a 12-hour shift, having to spend 2.5 hours going to a therapist's office is an added burden when you have to go home and take care of your kids. So then thinking about, and these are not, thinking about where these sort of tiers fall in this continuum, right? So, and these are not hard and fast. They blend all over the place. There may be times where a person having a mild reaction would benefit more from a leader interaction, or an organizational intervention than peer support. And there are times where someone who is more on the injured end of the spectrum still needs peer support, right? That they have not been abandoned by the team or cut from the herd. But again, the idea is to think in ways that aren't just focused on these people. Because if we react as a system to focus on, and I'll use this as an example, and this is something that I think we may be potentially taking ourselves in a less helpful direction. But if we focus, for example, on suicide prevention, and we start treating every distressed person as if they might be suicidal, what does that do to that person? Are they looking to come into the system, or do they want to hide out until it's so bad that they actually are suicidal, right? So thinking about how you set up your system of support, and not just your system of care, to get to these people, but in ways that makes it approachable. The last area I want to touch on is this idea of phases of support, and there are different things that people need at different times. So if you were to look at sort of the military deployment cycle, obviously preparation is typically about, one, screening people that already have serious disorders so that you don't send them into the dangerous environment, and maybe either excluding them or getting them some additional support or delaying their transition to combat, whatever. But it's a lot about screening. It's also a lot about psychoeducation and teaching people about what types of reactions are normal. Some of that is through sitting down with a mental health person and talking about it. Some of that is through actually going out into very intense training environments and experiencing it and developing a sense of mastery. But it's very much about education and screening. Sustainment would be, what do you do when you get them over in a deployed setting, and how do you ensure that people aren't just sort of falling apart and you don't know about it? And much of that is done at a leadership level, but there are mental health personnel that are always deployed with combat units that are, and part of what they do is unit needs assessment. So say when a significant event happens, then the attached mental health people will be sort of called out and start talking to people and maybe doing some instruments, but getting a sense of how everybody's doing, and giving feedback to leadership about what things they might do to get people back up and ready. And then recovery and reintegration is something that I think in the military, we've applied a lot more thought to, and the idea of you don't just come back and everything's fine, right? So you don't spend 6 months knocking down doors and come home and feel the same walking through your own door. You don't spend 6 months patrolling in dangerous crowds and walk into a crowded store and everything's fine. So teaching people and supporting them through this recovery and reintegration process, we have learned, is very important. And so you can identify some of the same things with healthcare. And unfortunately, preparation is not always something we get the luxury of doing. So whether preparation, in many ways, most hospitals do some sort of mass casualty drill or training, and people understand their roles, and they exercise it maybe once a year or every other year so that people get a chance to practice it. So that's a good thing. That's a form of preparation where people can put themselves in the experience, get a sense of mastery, and they feel like they're ready if and when it really happens. Now, with infectious outbreaks, it was sort of a slow rolling mass casualty. We saw the wave coming. We were hoping it wasn't going to come to our hospital. In some cases, we lucked out, and in some cases, we didn't. But in most cases, there was at least a little bit of time to start thinking about, okay, how do we start to make sure that adequate personnel are in place? Can we get some of the resources? Can we start training people on, especially people that haven't put on PPE in months? They got trained on how to wear the PPE and what it does for you, and how it protects you. So things like that we were able to do. And then, but honestly, there's going to be stuff that we're not ready for, right? So the idea of having multiple patients dying in isolation, that was a stress that you could say we could have reasonably anticipated, but it was nothing like what we've experienced. So preparation is never going to be perfect, but trying to think through as many and educate people about what they can encounter and how they can protect themselves, and what the organization is doing to protect them, is a key part of preparation. But then once the wave hits, what do we do? And this part I'll come back to and give you some examples. But what are things that we've done to help people, to help, whether it's nursing staff or, we're also learning that healthcare workers are not just doctors and nurses and techs, right? They are the custodial staff that have to go in and clean up the unit after the patient's, after the body's been removed and the room has been isolated for a period of time. But that develops a wear and tear on them as well, and as well as the administrative support that are sitting at the nurse's station, and or the care managers that are coming around and making all, having all these different interactions. So recognizing the broad healthcare workforce and how we support them. Recovery and reintegration, I worry, is something we haven't thought enough about. And it's something I tend to be rather passionate about. We had a symposium a year and a half ago at the university where various physicians talked about their experiences coming back from their combat deployments. And so these are trauma surgeons, internists, I mean, you name it, but they worked in very stressful settings with repeated distressing events. They came home, and in some cases, it was expected to just be business as usual with no acknowledgement of where they had been and what they had gone through. I worry that we may be setting ourselves up to do the same thing with our healthcare workers when they come back to the family medicine clinic after spending 2 months, augmenting the hospital because that's what they needed. And people either looking at them like they're afraid to talk to them because of they don't want to open up the can of worms, or that they don't even acknowledge that what they've been through, and just, okay, well, we need you back on the schedule, right? Your RVUs are not up to where they should be. So things like that, and recognizing that these people have been through a challenging experience, a distressing experience in many cases, and they may not be the same right away when they come back. And the system tends to expect them to just come back and be the same and do what they were doing before. And that may not be the case. So I said I would give you some examples. So the Healing, Education, Resilience, and Opportunity for New York's Frontline Workers, or HERO New York, that was something that we were a part of. And this was geared towards, it was sort of a train the trainer concept, and it was a series of 5 modules that were offered to primarily wellness support staff in hospital systems throughout New York City. It was towards the tail end of their COVID surge when they recognized that their workforce was really stressed, but it was meant to put tools in their hands, reinforce concepts that many of them already knew, but really give them some ways to approach this in those ways that I described. In terms of peer support, University of Minnesota Health System came up with this Battle Buddy support program. And I got to say, this was just amazing that they had an idea where they paired people up, and everybody got a battle buddy, whether you wanted one or not. It was just sort of, this was the policy, this was the program, and they could use it as much or as little as they wanted to, but you had somebody that was your go-to. But part of that also meant that you met with you checked in with your battle buddy on a regular basis. It became part of the routine. And so things like that, where it's a minimally intrusive part of the routine and it's sanctioned by the organization, can be very powerful. Now they don't have data yet. I haven't seen any papers up, but I know they're studying it and studying the outcomes associated with their Battle Buddy support program. And then finally, Mount Sinai Health System had, we consulted with them quite a bit, but their initial approach was kind of the standard, let's get some hotlines and some clinical care, and they wondered why nobody was showing up. And after we met with them, they changed their approach to have a more embedded model, and that is social workers and some other clinicians kind of attach themselves to various units within their hospitals, and just would drop-ins. And it's not intrusive. It's meant to be sort of part of the natural rhythm of the unit. So if there's a shift turnover, a shift meeting, maybe they might be there for that, and they might only get 30 seconds to throw out one little pearl. But at the same time, they become a face and a presence that's recognized as a mental health person that's here with me, and that's, you know, that understands and that sees what my day-to-day life is like. And so that really increased their credibility and their accessibility within their different units around the hospital. So again, this was that the Sinai example is really one of embeddedness rather than sort of sitting back and trying to get them to come to you. There's many resources available out there in terms of understanding psychological first aid, thinking about how to apply it with healthcare workers, but also how to apply it with supervisors and leaders. If things are really sort of headed off the rails and you need something now, well, here's some rapid resources. And again, Patty, feel free to share these slides as you will, but these links, you know, we keep a series of a whole collection of just really short 2-pagers that are something that if you're in a hurry and you got a lot on your mind, but you got something that you have a specific question about and it's specifically related to a disaster or a disease outbreak, we probably have a fact sheet on it that you can get some quick pearls and stuff that I can do now. And with that, I'll stop. And I think I stayed pretty close to within my time frame. And I will be happy to take any questions or any discussion that you might have.
That was outstanding, and I appreciate the way that you have modified your presentation just a little bit from the Arkansas Psychiatric Society and given some really practical tools and approaches that we as individuals within a healthcare system or within our families, within our communities can do, but also that our hospital systems and leaders and it's not just the CEO of the hospital, but it's, you know, mid-level and us just in day-to-day. So I see the practicality of that and I appreciate that.
Yeah, I think one of my great lessons that I learned, again, when I was working out with units out in the field was you gain an appreciation of how much influence a mid-level leader has. And that's honestly one of the things I learned pretty quickly was I could try and go around and talk to 20 individual Marines when I was visiting a post, or I could go find the room where the staff sergeants came to grab a snack or just hang out after their patrols, and I could have a lot more influence that way by just having some brief interactions with these mid-level leaders, and they would walk away from that both a little more psychologically minded. Maybe they brought me a problem that they wanted my opinion on, or maybe they didn't, and I just asked them some questions and got a conversation going. But that was one of my biggest bang for your buck kind of interventions. Now, here's the trick, and I don't have the answer to this, is how do you account for that within a healthcare system that wants to account for your productivity? And so this is the challenge. I don't have the answer yet, but and I don't think the military actually came up with a great answer either. We tried to come up with all these different tracking systems to show the amount of time that we would spend talking to different people, and none of them ever worked. Like, you know, the medical record system where the coding information was there. So what was measurable was easier than what was meaningful.
Yeah, and I'm sure we have some people on the line that are integrated behavioral health personnel. And from my own experience as a psychiatrist at the VA, and I was co-located in a primary care clinic, I totally enjoyed working with patients who I saw get better. But I also saw that informal support to all the different people in the clinic. The doctors would come in or staff would just kind of come by and say, hey, I have this patient, and they would tell me their stories. And so I thought that was probably the best value that I provided. But it's hard for leadership to say, well, how can we afford to put these clinical personnel, psychiatrists and licensed personnel in systems where they're doing things that you can't measure or get paid for?
Right. And how do and like you said, those are so fulfilling, because not only do you see the patients get better, you also typically see the quality of referrals get better, because the primary care people are recognizing, what types of things really need your attention, and what types of things, again, it's partly empowering them. It may be giving or reinforcing knowledge for them that they can apply. And so those curbsides are so amazing and fulfilling, and yet you can't bill for them.
Right.
And how do you convince the system? Well, yeah, but I got to tell you, you're using my time so much more efficiently now. And those 15 minutes that you lost while I talked to this nurse practitioner or whatever, believe me, you're more than making it up, because the patients that they are sending me really need my help.
Yes. And I know we're short of time, but I do want to make sure everybody knows we are going to post this recording on our Arkansas Behavioral Health Integration Network website. And so we will also have the PowerPoint slides. If for some reason you don't get it, feel free to send me or Kim an email, and we'll make sure that you get it, and we can continue the dialogue. If you have specific questions for Dr. West or for any of us, we will be glad to forward those. Because one of the great things about these webinars are the relationships that we can develop. And it's not just a one-time piece of information, but that we can continue to grow and move forward. Go ahead, Kim. Sorry I interrupted.
Oh, no worries. I just wanted to say we did have a question, and so I'm going to go ahead and ask the question, Dr. West. The question is, in your experience, how do teams that reunite broach hurt feelings over someone who may have been furloughed and some who were not? Or similarly, some who chose to work from home during this pandemic and some who did not. So any thoughts on that?
Oh, yeah. And I will tell you, this is something that we see. I'm not going to, well, I mean, there's military examples, but there's hospital examples, right? So in many cases, people either self-selected or because of health risks were identified as, it's not safe for them to work in these these riskier environments. And yet before that, before it was a risky environment, let's say you had a ward clerk, right, who had multiple health risk factors, and they got moved off the ward when it became a COVID unit. But prior to that, they'd been a fairly cohesive team. Maybe they liked him, but then he's gone for a while, and then he comes back, and everybody's got all these experiences, and that individual doesn't. And and it can be perceived a whole bunch of different ways. Is that person, were they getting out of something, right? That's one negative perception. Another would be is that we've all got this shared experience and you don't. And they may actually be very, like you said, they may be very self-conscious that, I didn't do my part, even though I couldn't. In those circumstances, I think it's very important for something to come from the leadership and a message to come from the leadership to say, look, we're back together and our teams are back together. And while everybody contributed in different ways, everybody contributed. And to value that contribution. And to not allow people to be singled out or feel like they're somehow less than because they weren't there when this was going on. And maybe they have health risks that they don't want to disclose to their colleagues. That's fine, and that's their privilege. But to encourage a mindset amongst everybody who did go through it to say, look, this doesn't make you better than, but it means that you've got a unique experience. You made a great contribution. We're going to recognize that contribution. That doesn't mean that these other people are in any way less either. and that we've all had a job to do, and we did it in different ways.
Thank you so much for your response. I know you have a hard stop at 9. So I want to thank everyone today for their participation, for joining us. As Dr. Gibson has said, we will have the recording and the slides posted on our ABHIN website. And we thank you so much for your time and being so gracious with sharing all of a little bit of your skills with us. I've learned so much from today's presentation, and we'll see you all next month.
Thank you so much. It was my pleasure.